Today we are going to start complete endocrine physiology revision series. So first we need to start with pituitary gland. So pituitary gland is also known as master gland, and for this master gland there is one more head, that is our hypothalamus. So from the hypothalamus there are either releasing factors or inhibiting factors. So according to these factors the pituitary gland works. So if there are releasing factor, it will stimulate the hormone, it will release a stimulating hormone which mainly act on different kinds of endocrine glands, and that endocrine glands mainly produce hormones. So our main in our endocrine physiology, our main target is production of hormones from different types of endocrine glands. So this is how our system works. Like if there is inhibiting factor, then this process will be inhibited and finally that hormone will be not produced. But if it is releasing factor, you can see a positive sign, means finally the hormone is produced. So hormones are mainly released from endocrine glands. Inhibit pituitary gland and hypothalamus by negative feedback mechanism. So actually, as we said, this is a positive feedback mechanism. There is also a negative feedback mechanism that is given by hormones. That is, for example, if some kind of hormone is excess in our body, then this hormone gives a negative feedback. It may also inhibit the pituitary, may also inhibit the hypothalamus. That feedback, we know that negative feedback we already discussed in our general physiology, right? Negative feedback is whenever any kind of hormone is excess in our body, then it itself inhibits the pituitary gland, that's saying to it stop producing more hormone, and even it may also inhibit the directly hypothalamus, which is the head of a pituitary gland. So it may also say to hypothalamus to decrease the production of that specific hormone. Now let us move on to the types of pituitary glands. So pituitary glands are mainly divided into anterior pituitary and posterior pituitary. So actually posterior pituitary is direct cranial connection from our hypothalamus, whereas anterior pituitary is formed from Redcase pouch, right? So this all we know, these are the basics, right? So first, anterior pituitary. Anterior pituitary mainly produce a lot of hormones, like 6 hormones. So the first hormone which is useful for growth of an organism, that is growth hormone, and prolactin, which is useful for production of milk from the breast during mainly pregnancy, lactation, and thyroid stimulating hormone. It mainly produces T3 and T4 and adrenocortic hormones, and we have follicle stimulating hormones and luteinizing hormones. These are useful for reproduction. So this follicle stimulating hormone and luteinizing hormone together are also called as gonadotropins. And next let us see mainly the two types of cells which are present in the pituitary. So mainly we have acidophilic cells and basophilic cells. According to name you can understand, acidophilic cells are the one which take acid dye, and basophilic are blue color, acidophilic are red color, right? So these acidophilic cells are mainly called as twin hormones. Twin hormones are produced from the cells, that is they produce the growth hormone and prolactin. So growth hormone and prolactin are twin hormones, remember that. And basophilic cells, they mainly produce all the remaining hormones of our anterior pituitary. Those are like thyroid stimulating hormone, adrenocorticotropic hormone, FSH, LH. So anterior pituitary mainly contains also different hormones, that is corticotrophs. Corticotrophs mainly produces the precursor molecule called as pro-opiomelanocortin. So we need to divide it into pro-opiomelanocortin. So pro-opio, from pro-opio, it forms mainly endorphin, which is an opioid, and melano, in the name you can see it forms melano-stimulating hormone, and cortin mainly releases our adrenocorticotropic hormone. So you can see anterior pituitary contains corticotroph. It produces precursor molecule. So corticotroph is the one which is producing a precursor molecule, that is POMC. This POMC full form is pre-opiomelanocortin. Pre-opio produce an opioid, endorphin. Melano produce melanocyte stimulating hormone. Cortin produces adrenocorticotropic hormone. So whenever there is excess level of ACTH, then it can lead to hyperpigmentation, especially in Addison disease. So actually normally you may get confused, like melanocyte stimulating hormone may cause the hyperpigmentation, but whenever this ACTH is excess, it may convert into, it converts its function into melanocyte hormone, so it leads to hyperpigmentation in Addison's disease. And next, let us move on to posterior pituitary. So posterior pituitary, everyone thinks it produces two hormones, but it's false, because posterior pituitary is just a storage site. The two hormones, that is ADH and oxytocin, are produced from the hypothalamus, but they're stored in the posterior pituitary. So you can see posterior pituitary doesn't produce any hormone. It is associated with storage and release of vasopressin and oxytocin. Both vasopressin and oxytocin are produced in hypothalamus. The storage bodies of this vasopressin and oxytocin are called herring bodies. This is important. And next, let us move on to growth hormone. So growth hormone, we know it's one of the twin hormones, and it is produced by acidophilic cells. That also we know, because both twin hormones are produced from acidophilic cells. And remember, both hormones, both these twin hormones, have the common receptor like Janus kinase pathway, that is also called as JAK-STAT receptors. So especially, let us say about growth hormone. Growth hormone levels vary with age, according to age. So maximum growth hormone is seen in adolescence, and lowest growth hormone is seen in, of course, old age. So regulation of growth hormone secretion, of course, this is also by our head, hypothalamus. Hypothalamus may give a signal by positive signal, that is growth hormone releasing hormone. In the name itself, you can understand this will increase the growth hormone secretion. On the other side, we have growth hormone inhibiting hormone, that is also called as somatostatin. So actually, remember, somatostatin is a universal inhibitor, that is, it inhibits everything in our body. So it's a negative, which of course decreases the growth hormone secretion. So now we have one more new one, that is sermorelin. So sermorelin is actually growth hormone analog means similar to growth hormone. So of course, what it does, it's used in treatment of pituitary dwarfism. Of course, by this only you can understand, by this line only you can understand, pituitary dwarfism means the person is dwarf because of not having growth hormone. So here, by using this sermorelin, we can treat this so that a person can get back to normal. And another one is Octreotide. So Octreotide is a somatostatin analog, means it is which inhibits the growth hormone. This is used in treatment of acromegaly, because acromegaly has lot of growth hormone, so we need to inhibit the growth hormone by use of Octreotide, which is a somatostatin analog. And next, let us see what are the factors which are affecting the growth hormone secretion. So increase in growth hormone means high amounts of growth hormone. For example, low blood glucose, that is hypoglycemia. Hypoglycemia will lead to increase in growth hormone secretion. So growth hormone increase glucose in body, that is hyperglycemic or diabetogenic hormone. So for example, if you are in starvation, like for long days, or fasting for long days, then your growth hormone in your body will increase. Because of this, it will lead to increase in glucose in the body, and that will lead to hyperglycemic or diabetogenic condition. So the factor which stimulating the growth hormone, increase in growth hormone secretion, is hypoglycemia. And next one is fasting, of course, as I said, starvation, exercise. Even in exercise, lot of when you do exercise, your glucose, your calories cut down, right? So because of that, that is nothing but again hypoglycemia. Then of course it will increase the growth hormone. And even in stress, and also even in the sleep, also growth hormone increases. But in sleep especially, there is a condition like non-REM sleep, especially in stage 3 and stage 4, that is no rapid eye movement is seen in this kind of sleep. In that sleep only, there is increase in growth hormone. Next, let us see where the growth hormone is decreased. Growth hormone is decreased, of course, by somatostatin. It is an inhibitor. And also sleep. What kind of sleep? REM sleep means rapid eye movement. Whenever there is rapid eye movement sleep, remember, there is decrease in growth hormone. But whenever there is non-rapid eye movement sleep, there is increase in growth hormone. So that is differentiation here. And next, let us see actions of growth hormone. So it is having direct action and indirect action. Direct action is anti-insulin like action, so it will lead to hyperglycemia and also lipolysis. So lipolysis, it will cut down the fat, and it will also increase the glucose. Just now we have seen, when our growth hormone is more, it will increase the glucose. So it's anti-insulin like action. But indirect actions are mediated by some somatomedins. These somatomedins are actually produced by the liver, and these somatomedins are also known as insulin like growth factors. That is, they have insulin like an action, that is anti-lipolysis. So insulin, what it does, it doesn't allow lipolysis, means it allows it doesn't allow to break down of lipids, right? But whereas this direct action of growth hormone is anti-insulin like, so that's why here hyperglycemia, lipolysis, but here indirect action is anti lipolysis. So action of growth hormone on bone growth, it involves both direct and indirect action. So here you can see in bone growth, both direct and indirect are involving. Conversion of pre-chondrocyte to mature chondrocyte is direct action of growth hormone, whereas further bone growth is mediated by somatomedins. So whenever you can see the word mediated, it is medins, you can see somatomedins act there. They are insulin-like growth factors, whereas the direct action is anti-insulin like action. So somatomedins are the one which are insulin like growth factor. Next, let us see growth hormone disorders. There are some disorders like, for example, if there is excess of growth hormone, then it may lead to gigantism in children and acromegaly in adults. So A for A, you can remember like that, acromegaly in adults. And whenever there is, of course, deficiency of growth hormone, it will lead to dwarfism. And there is another syndrome like, another disorder like Larynx Dwarfism. Larynx Dwarfism is rare. There is only mutation of growth hormone receptor, but the growth hormone level in the body is normal. Growth hormone is normal, but the receptor to which it should act, that is abnormal. In that case also, of course, it will lead to dwarfism, right? And here there is decrease in plasma IGF, that is insulin like growth factors, that is nothing but our somatomedin. So here the somatomedin level is low, but the growth hormone level is normal, and there is mutation in growth hormone receptor, that is Larynx dwarfism. And next, let us see about prolactin. So prolactin is our twin of growth hormone, right? So this prolactin is also released especially from anterior pituitary, and this is synthesized by acetophilic cells. Main function milk production. And dopamine, which is synthesized by hypothalamus, is an inhibitor of prolactin. So we are seeing like all the factors which are coming in the beginning we have discussed here, like from hypothalamus they are coming positive effect, negative effect. Even from the pituitary there is positive effect and negative effect for the production of hormones. If pituitary gland is stimulating, then it will form hormones. If pituitary gland is negative, then it will drop the production of hormones. So here actually from anterior pituitary all hormones are stimulating except prolactin because of release of dopamine from the hypothalamus. It is having an inhibitory effect on prolactin, so it always inhibits the prolactin. But the factors which are regulating prolactin secretion, like whenever there is increase prolactin secretion is especially increased in pregnancy and lactation, and also during suckling of baby from the nipple, and also whenever there is sexual intercourse, or whenever there is sleep, especially rapid eye movement sleep. So in all these conditions you can see there is higher amount of prolactin. And decrease in prolactin, of course, our major one, dopamine, as we discussed. Dopamine from hypothalamus inhibits the production of prolactin. This is a normal state. So analogs to it like L-dopa and bromocriptine, so like agonists, or bromocriptine is an agonist of dopamine, so they all inhibit the secretion of prolactin. So next, let us see what are the functions of prolactin. So functions of prolactin is mainly production of milk, and it also have negative regulator of reproductive function. It may lead to lactational amenorrhea, that is whenever a mother is in lactation phase, it is like contraception where there is amenorrhea, that is all the reproductive functions are blocked, that is negative regulator by mainly inhibition of gonadotropin releasing hormone by prolactin. So prolactin is the one which inhibits the gonadotropin releasing hormone, so that is the reason why there is amenorrhea. So this is all about our pituitary gland. Next, let us continue our series with another one. Continue our revision series of endocrine physiology with now thyroid gland. So we know thyroid gland mainly produces the hormones T3 and T4, but where from these hormones are coming? They are mainly released from the follicular cells. And beside the this follicles, we also have C cells which are parafolliculars, and they mainly produce a calcitonin. So T3, T4, calcitonin are mainly produced from the thyroid. So these are the hormones of the thyroid gland. So actually now thyroid is like this formation of T3 and T4 is something like we are now preparing one food recipe. So for that food recipe, now let us see what are the ingredients first we needed. So the main ingredient which we need, especially we need two ingredients, that is amino acid tyrosine and also an iodine. So this amino acid tyrosine is actually coming from the globulin protein, that is thyroglobulin, and iodine is directly coming from the diet. but actually it is in a reduced form, that is iodide. But this reduced form should be converted into oxidized form, then only our thyroid gland can take it up and form the T3 and T4. So these are the two main ingredients which should be provided to the follicular cell, and this follicular cell finally produces T3 and T4. So here we can see this diagram to understand. Let us try to understand this diagram. So this is a follicular cell in a thyroid, and here we have basolateral side of a cell, and this is apical side. On the basolateral side mainly we have a sodium iodine symphoter. Actually iodide in our body, always iodine is in the form of iodide in our diet. So mainly in the blood vessel we get this sodium and iodide which is from this blood vessel. Of course, in this blood vessel, how they have come by dietary iodide or sodium, already we know, either in dietary iodide or from the cells. So like this, in this blood vessel, it travels into this follicular cells at the basolateral side. So remember, at the basolateral side of follicular cell we have sodium iodide imported, and this brings sodium into the cell and also iodide into the cell. The iodide which has come into the cell is going again back to the apical side and going out of the cell. Why? Because the iodide cannot be used directly by the thyroid cell to form the hormones. So this iodide is reduced form, and it should be converted into oxidized form in the presence of an enzyme called thyroid peroxidase. So thyroid peroxidase is an enzyme converting reduced form of iodine into oxidized form. And here you can see the iodide is going out and the chlorine ion is coming in, because we need to balance the negativity of the cell. As one negative charge is going out, chlorine, the negative charge, should come inside. This is iodine chloride antipode, because both are traveling in opposite direction. So it's in the apical side. So on the basolateral side we have sodium iodide symphoted, and on apical side we have iodide chloride antipode. So after getting all these ingredients, the thyroid now easily makes a T3 and T4. So how they are formed, we have some coupling reactions there. Before that we will see what is, let us see this explanation. So TPO in short form is nothing but thyroid peroxidase. So thyroid peroxidase is a cell membrane bound protein. It will be especially on the apical side of cell membrane, on the cell membrane bound protein. And this TPO blockers, there may be some TPO blockers which are nothing but anti-thyroid drugs. Why? Because if this iodized reduced form is not converted into oxidized form in the presence of thyroid peroxidase, then it's not used by the thyroid cell to form the hormone. So we can say it as anti-thyroid drugs. So thereby they decrease the T3 and T4. So what are these anti-thyroid drugs examples? We have propyl thiouracil, in short form we call PTU, and we have carbimazole, methimazole. So these are the three drugs which we use to prevent increased thyroid in the body. So next we have sodium iodide symphoter, also known as co-transporter. It's also found in parotid gland, that is salivary gland, mammary gland, and also in the placenta. Remember, these three cells are also capable of taking iodide inside the cells, and they also have the co-transporter, that is sodium iodide symphoter. And whenever you see this co-transporter, it is always a secondary active transport process. And next, whenever there is excess iodide coming in a blood vessel, or when it is coming to this especially this sodium iodide symphoter, then it immediately inhibits the T3 T4 synthesis, and this is called Wolff-Chaikoff effect. That is, whenever there is excess iodine in a body, then it directly inhibits the production of T3 and T4. Now let us see. Now come back to this diagram. We have said we have got all these ingredients. We have now converted the iodide from the diet into oxidized form. All these ingredients, how mainly this T3 T4 are forming. This is the main process, that is the coupling reactions. Here the oxidized form of iodide and the tyrosine, which is coming from the thyroglobulin, right? So this is an amino acid. So this both bind together and form a monoidotyrosinase. And this monoidotyrosinase along with other monoidotyrosinase both together form diiodotyrosine. And this monoidotyrosin can also bind with directly diiodotyrosine to form T3. So T3 is an active form, And next we have Diidothyros with monoid. Already you've seen this one, but this time it is binding in a reverse way, and here it's called reverse T3, which is inactive. When diiodothyrosin can bind with other diiodothyrosin to form T4. So this is how T3 and T4 are formed in the follicular cells, and this follicular cells, especially in the colloid, they are stored, you can see in the follicular cells they are stored in the form of colloid, and this colloid has hormone reserve for like about 2 to 3 months. So this is this T3 and T4 are reserved in the colloid for 2 to 3 months, and when colloid breaks down, it releases T3 T4 into the blood vessel directly. So now let us see what happens in the blood vessels. So thyroid hormones in blood vessels. So before going to blood vessels, we need to see one more point here, that is about this iodide chloride antipode which is present on our apical cell, right? This one, about this one I am talking. So this is also called as pentrin. Why it is called as pentrin? It has some reason. For example, if there is any mutation in iodide chloride antipode, then actually this antipode is present in two areas. One is in thyroid, we have seen apical site, and in an inner ear also. So whenever there is mutation, it will lead to goiter, because lot of iodine can't go out of the cell and get accumulated in the thyroid, and it will lead to goiter. And even in the inner ear, the iodine will get accumulated and it will lead to sensorineuronal hearing loss. So whenever there is mutation, they will cause this, and this together called Pendred syndrome. Hence this iodine chloride antipode also got a name as pentrin. So now let us go into the blood vessel. So what happens to thyroid hormones after getting into the blood vessels? So T3, T4 in the blood vessels are either in a free form or in the bound form. The free form is just 1%, but it is an active form, whereas the bounded form is 99%, it is an inactive form. So how it is bound, with what proteins it is bound, let us see. Mainly it may bound with either albumin, either with thyroid binding proglobulin, or with transthyretin. So let us see one by one. If it binds with albumin, it has 20% binding with albumin, and thyroid binding globulin is most important among these three, and it is also called TBG in short form, and 70% binding is going on here. And the last one, 10% binding in transthyretin. It's common for binding of T3, T4 and vitamin A. In the name itself you can see transthyretin, retina like so, binding with vitamin A. So this is also called as pre-albumin. So now let us see how to regulation of thyroid hormones. So of course the head for any hormone which is coming from pituitary gland is of course hypothalamus. So from the hypothalamus mainly thyrotropin releasing hormone is released. You can see here thyrotropin releasing hormone is released, and this thyrotropin releasing hormone stimulates the pituitary gland, and this pituitary gland releases a thyroid stimulating hormone. In the name itself you can see it stimulates the thyroid gland to produce T3 and T4, and in the peripheral tissue the T4 is converted into T3 because T3 is the active form, and this T3 also have a capacity to do the negative regulation, that is negative feedback on either pituitary gland or on the hypothalamus. Remember, only T3 have the capacity to negative regulation. So you can see here TRH is thyrotropin releasing hormone, released THS from anterior pituitary. So remember, TRH is from hypothalamus, TSH is from pituitary gland, and T3, T4 from the thyroid. So TSH, what thyroid stimulating hormone does? It also produces T3, T4 from the thyroid gland. At the same time, it also increases the vascularity. It also increases the iodine trapping capacity, and of course, this both will help in increase the T3 and T4. So now let us see the receptors and transporters of thyroid hormone. So now we have got the hormones, but we should also have the receptors by which our hormone work and change the metabolism of the cell. So here you can see T3, T4 mainly act by direct nuclear receptor. So direct nuclear receptor means it can directly act on the nucleus, but you may think that these are proteins, right? But how proteins enter into the cell? Mainly it have two types of transporters, that is MCT and OATP. So MCT is monocarboxylate transporter, and OATP is organic anion transferring polypeptide. So by means of these two proteins, T3 and T4, especially our T3 is active form, it enters into the cell and act on its nuclear receptors. So now let us check out the differences between T3 and T4. So T3 is the most potent, as we said, the most active one, whereas the T4 is less potent, less active, and there is rapid onset of action by T3, whereas there is slow onset of action by T4, and the short half-life is also short in case of T3, whereas T4 has long half-life. So as it's having short life-lives, it is less in the circulation, means in blood vessels, whereas T4 has long half-life, so it's more in circulation. So by this half-life and in circulation only, we can say that T3 is more potent because it's staying less time in the blood and having more effects on the cell. But T4, you can see it's like happily resting in our blood and not going into the action. So it's less in colloid, it's more in colloid. That's what here you can say T3 is not resting more, it's going to the action, whereas T4 is more in colloid because it's stored in the colloid. And mainly T3 is responsible for physiological action, whereas T4 is responsible or important for pharmacological actions. So now let us see the actions of T3 in detail with this our active form. So T3 mainly regulate the basal metabolic rate, that is nothing but they increase oxygen consumption, and they also in electron transport chain they have a role, like T3 acts as a physiological uncouplers and increase the body heat, so that it is also called as thermogenic action. So body heat is increased by our thyroid glands, and also basal metabolic rate is increased. And in person with mainly hypothyroidism, there is low T3. As there is low T3, a lot less heat is produced in the body, so these persons are always called cold intolerant. That is, as heat is producing low in their body, they can't be more in a cold places. And in persons with hyperthyroidism, they have higher T3, so they have a lot of heat production, so they are heat intolerant, they can't stay in heat for a long time. So now let us see what is the metabolism by our thyroid hormone. Remember, thyroid hormone is a universal catabolic hormone, that is, it's having mainly braking properties. So carbohydrate metabolism, it increases blood glucose level, and lipid metabolism, it leads to lipolysis, increase free fatty acids in the blood. So especially in hypothyroidism, as you can see, there's a lot of lipolysis, increase in cholesterol in the blood. So because of this, there is hypercholesteremia. This will have a higher chance of atherosclerosis, of course leading to many heart diseases. And protein metabolism, it's proteolysis. So you can see everywhere lysis, we are breaking down everything, we are decreasing. So hence metabolism of thyroid hormone is mainly catabolic in nature. Next, let us see the developmental role. It promotes brain growth, bone growth. So whenever any defect, and then it will lead to congenital especially in congenital hypothyroidism, the child will have both mental retardation, at the same time stunted growth, because if thyroid is there, will be normal brain growth and also normal bone growth. But if the thyroid is absent, especially in congenital hypothyroidism, so the child will have both mental retardation, at the same time stunted growth. Next, let us see what is going in heart because of thyroid. Indirect action of T3 increases responsiveness to heart, mainly to catecholamines like norepinephrine via beta receptors, and increase the heart rate, of course, and also increase the myocardial contractility. So thyroid storm is a state of emergency in thyroid patients, and it is treated by propranolol, so which is a beta blocker. So mainly what thyroid does is it indirectly increases sensitivity of heart to catecholamines, especially norepinephrine. Norepinephrine acts on beta receptor and increase the contractility of the heart, at the same time also increases the heart rate. So sometimes if a patient is having thyroid storm, like lot of thyroid hormones, then it will lead to a serious condition, so we need to treat it as an emergency, mainly by propranolol, because propranolol is a beta blocker. And next, that's it about this chapter. We completed thyroid gland. Next we'll see another endocrine gland. Channel, let us continue the endocrine physiology revision series. So now we are at endocrine pancreas. So endocrine pancreas, the main cells of pancreas and hormones which are produced, we are going to discuss them today. So the endocrine nature of pancreas is more prominent in its tail, that is its tail part according to anatomy. So the tail part have some islands of cell, that is nothing but called as islets of Langerhans. And these islets of Langerhans are isolated cells in the tail of pancreas, and these hormones produced by the cells of pancreas, these are the different cells of pancreas which secrete different hormones. So you can remember like A, B, D, F. Instead of C, it is absent. A, B, D, F. So A, B, D, F. A is for alpha cells which mainly produce glucagon. So glucagon is useful to increase the blood glucose. And B for beta cells which secrete insulin. So insulin mainly decrease the blood glucose, and beta cells also produce amylin. Amylin is stored and released with insulin. And and it potentiates the insulin action. So amylin is used to potentiate the insulin action, and we have Prolactin. Amylin is just a amylin analog used in diabetes mellitus treatment. So for amylin is used to increase the potency of insulin. So here we can also use this amylin analog like Prolactin. This is used in diabetes mellitus treatment. And next we have C-peptide. C-peptide is released in equimolar ratio along with insulin. So it's like 1:1 with insulin. And the marker for C-peptide, so actually to find out insulin levels in the body, we can also check out the C-peptide assay because they are produced in equivalent way, equimolar ratio. And the measurement of C-peptide reflects the insulin levels directly. Insulin producing beta cells form the major proportion of cells, 55%. So that is, among all these alpha cells, beta cells, delta cells, F cells, our beta cells is the winner because it is producing 55% of major portion, that to insulin. So among all these hormones which are produced by endocrine pancreas, our endocrine pancreas important hormone 55% is our insulin. Insulin is a winner among all these hormones. And next we have delta cells. Delta cells mainly secrete somatostatin. We know somatostatin is a universal inhibitor. It inhibits both, of course, insulin and also glucagon. And next we have F cells. F cells produce pancreatic polypeptide. In short, we can also call it as PP. So this is about an overview of different types of cells of pancreas and also their hormones. Now let us see our major hormone, our important hormone, insulin. So insulin has got a Nobel Prize for discovery mainly to Banting and MacLeod. So Banting is who found this, and MacLeod is a owner of the laboratory. Actually Banting and MacLeod are the one who got Nobel Prize for the discovery of insulin. And insulin structure mainly have 51 amino acids, and insulin structure was sequenced by Sanger. So S for S, it's sequenced by Sanger. And insulin first, why we put this heading? Because insulin is like related with many first, like for example, it's the first protein which was completely sequenced by Sanger, and first protein to be produced large scale by recombinant DNA technology for our users in patients who have diabetes. So for that it has large scale recombinant DNA technology to produce it. And zinc is the one which mainly stabilizes the structure of insulin, and it is stored along with it in the beta cells. So remember, zinc is the one which is used to stabilize the insulin. So for example, if we want to produce insulin in a market like synthetic insulin, we always use zinc with it so that it can stabilize it, and also it is stored along with it in the beta cells. And transcription factor for the insulin is hepatocyte nuclear factor, and this in short form is called HNF. This hepatocyte nuclear factor, if it has any mutation, then there is decrease in insulin levels, of course, because this is the one which is useful transcription. What is transcription? It will form mRNA, later it will form proteins, right? That protein is nothing but our insulin. So if this HNF factor is mutation, of course it will decrease the insulin level, and that is called MODY. MODY means maturity onset diabetes of young. Means this kind of diabetes is mainly seen in young people because hepatocyte nuclear factor mutation. Now let us see the important one, that is the release of insulin from the beta cells. So we are saying from the beta cells insulin will come, but we need to understand the process how it is coming. So blood glucose regulation is a negative feedback process. Means for example, if the blood glucose is increasing in our blood, means our insulin tries to decrease it. In the same way, if the blood glucose level is very high, then some other hormone tries to decrease it. As we saw here, glucagon increases blood glucose, insulin decreases the blood glucose. So for example, if in the blood vessels there is lot of glucose, then insulin will decrease it. But if in the blood vessel there is low glucose, then glucagon will increase the blood glucose. So like this, different types of hormones act, and finally they will regulate the blood glucose levels. So that is mainly a negative feedback mechanism. So increase in blood glucose, insulin will act and decrease in blood glucose. So it's a negative feedback mechanism. Now let us zoom into this cell and understand. So this is an insulin cell, beta cell, mainly beta cell. These are all islets of Langerhans, A, B, D, F, right? So these are all the cells. Now we are taking a zoom in of beta cell. So in the beta cell, for example, the glucose level is now very high in the blood vessel. So now what happens to this glucose? It enters into the cell. As it is entering into the cell, it will lead to, it is actually leading to increase in potassium ions because increase in glucose increase the ATP. This increase in ATP leads to close of potassium channels. After closing of this potassium channels, you can understand the potassium level inside the cell goes up. As the potassium is increasing, normally the resting membrane potential of the cell is -90, but because of positive ion, now it's getting depolarized, that is to -40 millivolts. So after this depolarization, what happens is the calcium channels start opening. Because of open of calcium channels, even calcium start coming into the cell. So now calcium, potassium, and in this channel, along with calcium, ATP, snare proteins all enter into the cell. So because of this entry of calcium, snare proteins and ATP, it will lead to exocytosis of insulin out of the cell. So this is how insulin is released into our cell, and now it will go and take up the glucose into heart, skeletal muscle, and also into different tissues. I will discuss them like on what it will do, how it will decrease heart, skeletal muscle, and adipose tissue. So mainly in this cells it will take up the glucose and it will finally decrease the glucose level in the blood. So this is the process of insulin. Now let us see this theory once again. It's like a revision. So whenever high glucose, high ATP is produced inside the cell, ATP sensitive potassium channel closes. So this potassium channel is also called as sulfonylurea. Why it is called as sulfonylurea receptor, I will say later. It is also, so remember but one thing, that potassium channel is also called as sulfonylurea receptor. And after that, the potassium level increases inside the cell and it leads to depolarization at -40 millivolts. And later, the voltage sensitive calcium channel open, in short form VSCC. Because of this, there is calcium influx. And because of this, not only calcium, along with that, ATP, snare proteins, insulin release. So because of entry of these cells, insulin undergoes exocytosis process and comes out. So insulin should stored in vesicles in beta cells, and it is released out whenever this entry of calcium, ATP, snare proteins. And the resting membrane potential is maintained by outward movement of potassium ions normally. But the steps of insulin release, what it does is mainly glucose is sensed by GLUT2 glucose sensor. So this is very important. GLUT2 receptor is on the basolateral side of a membrane. Here is the blood vessel. So whenever there is high glucose, the GLUT2 will sense it and it will immediately take up the glucose into the cell and store in the beta cell. After that, increase ATP, close the potassium channel, coming inside calcium, ATP, snare protein, release of insulin. So you can see here, glucose sensed by GLUT2 glucose sensor. This is the first step. Second step, closure of ATP sensed to potassium channel, so that potassium inside the cell increases and cell gets depolarized. And after that, opening of calcium channel. Because of this depolarization at -40, calcium channel open, entry of calcium into the cells, snare proteins, etc. Finally, exocytosis of insulin. So this is like a complete revision of our insulin release. So next, why it is called, I said this potassium channel is called as sulfonylurea receptor. Why? Let us understand the reason now. Because insulin secrete analog, this sulfonylurea is actually also called as insulin secretagogue. Why it is called as insulin secretagogue? Let us see. Mainly it closes the ATP sensitive potassium channel, and sulfonylurea is used in treatment of diabetes mellitus. You should understand this now. Whenever potassium channel is closed, means lot of potassium is increased. When lot of potassium is increased, lot of insulin is released. When lot of insulin is released, of course diabetes mellitus is cured. So that's why sulfonylurea is used in treatment of diabetes mellitus. And ATP sensitive potassium channel is also known as sulfonylurea receptor. So that is the reason it is also called insulin secretagogue. Means nothing but it is releasing the secreta, means in the word you can understand, it is releasing, secreting the insulin from the cell. That is sulfonylurea. So it is also called as potassium channel there. And next, diazoxide. So this diazoxide is actually a reverse of this potassium. So in this process we are closing the potassium, but here this opens the potassium. Understand, when it's opening the potassium, then a lot of potassium is continuously going out and insulin release will be dropped here. So it opens the ATP sensitive potassium channel, decrease the insulin release, and it is used in treatment of insulinoma. Insulinoma means already there is a lot of insulin in their body, so to decrease that insulin, now we use this drug like diazoxide. Now let us see the rapid action of insulin within seconds. So mainly whenever there is decrease in blood glucose, the major receptor for insulin is action is tyrosine kinase receptor. It mainly has 2 alpha subunit and also it has 2 beta subunits which are responsible for tyrosine kinase enzyme activity. And this tyrosine enzyme activity is mainly seen in the beta subunit. Of course, it has both alpha subunit, beta subunit, but the enzyme activity mainly seen in beta subunit. So what happens? Insulin comes, binds to its tyrosine kinase receptor. Because of this, what happens is there is uptake of glucose mainly by means of GLUT4 receptors into the heart cells, into the skeletal muscle cells, into the adipose tissue cells. Now all the glucose which is present in a blood vessel is entering into it. So GLUT4 transports the glucose into the tissue. Mainly this is facilitated diffusion, because a GLUT4 is actually a protein which is facilitating the diffusion of glucose from the blood vessel into this heart, skeletal muscle and adipose tissue. So this decreases the blood glucose level. And second point is, whenever there is a decrease in potassium ion in blood, insulin is also used to decrease the potassium ion in blood, because as the same way as insulin is taking the glucose from the blood vessel to the cell, even insulin also takes the potassium ion from the blood vessels into the cell. So insulin can be used in the treatment of hyperkalemia. So whenever a person is having high potassium in their blood vessel, we can use insulin because it takes the potassium ions into the cell. But there is a problem associated with it, that as you are giving more insulin to the patient, even the glucose also may go more into the cells and it may lead to hypoglycemia. So again, that will be dangerous. So to prevent that, we usually give insulin and dextrose to the patient in a combination of dextrose and insulin to prevent the hypoglycemia. Next, let us see the long-term action of insulin, that is hours to days. So before that we have seen rapid. Now we'll see hours to days. Insulin is a major anabolic hormone. So before you have seen thyroid is a major catabolic hormone, but insulin is a major anabolic hormone. It mainly favors the storage, and insulin is known as hormone of insurance because it's thinking about our future and storing a lot of them. So it is also called as hormone of insurance. So insulin mainly stimulates the glycogenesis, that is production of glucose, and lipogenesis, production of lipids, and also glycolysis. Why glycolysis? To use the energy and form ATP. And insulin mainly inhibits glycogenolysis, that is breakdown of glycogen, and also it breaks the process of neoglucogenesis, that is gluconeogenesis, the formation of new glucose, and also it inhibit the product of lipolysis. It doesn't allow lipid breakdown, and also it doesn't lead to formation of ketogenesis from ketone bodies from the liver. So these are all inhibited. So you can see insulin is like having all anabolic functions. And regulation of insulin secretion, the factors which increase insulin secretion are mainly glucose, glucagon, amino acids like arginine, leucine, and also gastrointestinal hormones like incretin, especially gastrointestinal hormone GLP, that is GLP-1, that is glucagon like peptide, and also it has a compound like exenatide, GLP-1 analog. It's analog of GLP-1. It's used in treatment of diabetes mellitus, because these are all which are increasing insulin. If insulin is more, then of course diabetes mellitus patients, it's beneficial for them, so that their hyperglycemia condition will be gone. And next, DPP4 degrades the GLP-1. So here you can see here GLP-1, we have understood about this function that it increases the insulin, but DPP4 is a negative effect. It's negatively degrading the GLP-1, means gliptins or sitagliptin as a DPP4 blocker used in treatment of diabetes, because if you block this DPP4, then there will be more GLP. More GLP means more insulin release. So this is used mainly for diabetes. And gastrin, secretin, cholecystokinin hormones are also increase insulin secretion. And factors which are decreasing the insulin secretion are of course our universal inhibitors, somatostatin and diazoxide. We have seen how it is inhibiting mainly by opening the potassium channel, and streptozocin and elloxone used to create experimental diabetes. These are mainly used to create the diabetes. Next, let us see the effect of autonomic nervous system on insulin secretion. So mainly we know autonomic means parasympathetic and sympathetic. So parasympathetic, when you're in peaceful condition, your insulin will increase mainly by vagal stimulation or either by acetylcholine, whereas sympathetic, it's a domain action is decrease insulin by alpha-2 receptor, which decrease the insulin dominant, whereas beta receptor increase the insulin. This is important. In sympathetic, normally insulin will drop, but in alpha-2 receptor dominantly it will drop, but in beta receptor it will increase. And next, let us see the counter-regulatory hormones. Insulin is only hypoglycemic hormone, means it is decreasing the blood glucose level. Blood glucose is 30 milligrams per dl. It may lead to coma, means if the blood glucose is also like 30 milligrams, it may lead to coma. So counter-regulatory hyperglycemic hormones are present in our body. Even though if the blood glucose drops so much, it may also lead to coma. So there are some hyperglycemic hormones like which are increasing the glucose in the blood vessel. First one comes the growth hormone. Growth hormones are dawn phenomena, means early morning there is, so you will see in early morning everyone will have hyperglycemia, means in blood vessel they will have high glucose mainly because of growth hormone. And next one, it's considered as physiological antagonist of insulin. It's an antagonist because it's opposite to the insulin. And also you have of course thyroid hormones which increase the glucose in our blood, and glucagon of course it will increase the glucose. In glucocorticoids, especially cortisol, they also increase, and we also have epinephrine, mainly corticolamine, which decrease the insulin and increase the blood glucose. Of course, if insulin is dropped, blood glucose will increase. So these are all the antagonists which are like acting reverse to the insulin. Insulin drops the blood glucose in the blood vessel, but these hormones, these different types, they try to increase the blood glucose level. So these are hyperglycemic and insulin is hypoglycemic. So this is all about our endocrine pancreas. Mainly we are talking about insulin. And next let us continue with adrenal gland. Start our adrenal gland. So adrenal gland is mainly divided into two parts. First is the adrenal cortex and other one is the adrenal medulla. So mainly the adrenal cortex is like about 78% of our total gland, whereas adrenal medulla is only 22% of the total gland. So this adrenal medulla mainly produces catecholamines. The important catecholamine which is produces, that is 90%, is epinephrine, and the next comes norepinephrine and also dopamine. So these are the three major products which are produced by our adrenal medulla, but the epinephrine is 90% among them. And next let us see adrenal cortex. It is like 78%. It is having different types of zones like cells, and from that again different types of hormones are produced. So mainly you can remember this as GFR, that is glomerulosa, fasciculata and reticularis. So GFR is a short form. So first one is our glomerulosa. So zona glomerulosa mainly releases a mineralocorticoid, that is nothing but our aldosterone. To remember this also we can remember like glomerulosa is where glomerular capillaries are present in a kidney. So this aldosterone is mainly acting on the kidney, and it reabsorbs the sodium and water. At the same time it also excretes the potassium and hydrogen. So according to its function, you can easily remember that from glomerulosa a mineralocorticoid, aldosterone is releasing. And next we have fasciculata. Fasciculata release a glucocorticoid. So you need to confuse between glomerulosa and fasciculata, that glomerulosa produces mineralocorticoid, whereas fasciculata produces glucocorticoid, and this glucocorticoid is none other than our cortisol. And next we have reticularis. Reticularis release some sex steroids like DHEA. The full form of DHEA is dihydroepiandrosterone, and another one is androstenedione. So these are two sex steroids which are released by our reticularis. So the zona glomerulosa cells act as stem cells to form the new cortical cells. So actually our glomerulosa is in the cortex, right? Since this glomerulosa can also have another function like stem cell function, it produces new cortical cells for our adrenal cortex. And zona fasciculata occupies the 50% of the area. Like among this glomerulus of fasciculator reticularis, fasciculator in middle, it is occupying 50% of the total area in a adrenal cortex. So next we'll move on to our major hormone, Halducerone, which is released from, it's a mineralocorticoid and it's released from glomerulosa, right? So aldosterone is a life-saving hormone mainly because of its functions. As we already discussed, it has resorption functions like sodium and water, and excretory function mainly excreting potassium and also hydrogen ions. The site of action where they work is mainly on collecting duct cells, and in that collecting duct cells especially we have two types of cells. One is principal cell and another is intercalated cell. Principal cell short form is P cell, intercalated cell short form is I cell. So actually in the principal cell there is sodium, water reabsorption and at the same time potassium excretion. So the main function of aldosterone is going on in the principal, hence the name principal. Intercalated cell is only having a hydrogen excretion function. So now let us go into zoom our principal cell to understand what's going inside it. So principal cell, it has of course basolateral side, apical side. Always remember apical side we have urinary flow and basolateral side we always have a blood vessel. So in a blood vessel, whenever we have aldosterone, this aldosterone comes from the blood vessel into the cell by means of basolateral, and after coming inside it binds with the mineralocorticoid receptor, and both together form a hormone receptor complex. And this hormone, actually remember, this mineralocorticoid receptor is present in the cytoplasm of a principal cell. After binding with it, it forms a complex. This complex goes to the nucleus of the cell. Inside the nucleus, it leads to two functions mainly. First one is upregulation of potassium channel. So here you can see this is a potassium channel. Upregulating means it allows the potassium to move from the principal cell into the urine so that potassium can be excreted out. And it also upregulates the ENaC channels. So what this ENaC channel does is it takes the sodium from the urine into the principal cell. That is nothing but reabsorption. So always remember, whenever the sodium is getting reabsorbed, even water follows it. So sodium and water are getting reabsorbed, means aldosterone is preventing diuresis. So this is reabsorption of sodium and water. So ENaC channels are full form is epithelial sodium channels. Aldosterone hacks here and increases sodium reabsorption. ROM potassium channel. This potassium channel is called ROM. What is the meaning? Renal outer medullary potassium channel for potassium excretion. And clinical correlation is that, for example, if this ENaC channel is overactivated, means lot of sodium is getting reabsorbed and also lot of water is getting reabsorbed, then it may lead to hypertension, because from here again it will go to blood vessel. So in blood vessel it will lead to hypertension. So Liddle syndrome, that is called Liddle syndrome. Overactive ENaC channel, increased sodium reabsorption and also water. By this it will lead to hypertension. And at the same time, as we have this overactivity, we also have some blockers of ENaC blocker, that is diuretic. Why it's diuretic? Because if you block this channel, the sodium and water can't get reabsorbed, so sodium and water is excreted in urine. There is nothing but diuresis. So we have an analog for that, or an agonist for it, that is a amiloride. So amiloride is used to cause the diuresis. So we have completed our principal cell. So principal cell only have main functions, that is potassium excretion, sodium reabsorption, water reabsorption. But intercalated cell only one work, that is hydrogen excretion. So now let us see what happens. We'll zoom on here and understand. So in the blood vessel we have mainly bicarbonate, and in the blood vessel we have chlorine. That chlorine is coming into the cell, and the bicarbonate from the basolateral end is going into the blood vessel. So this is mainly a chlorine bicarbonate exchanger, which sends bicarbonate out into blood vessel and takes the chlorine inside. And at the apical end we have hydrogen potassium exchanger, which excretes the hydrogen out into the urine and take up the potassium into the cell. So this is how the hydrogen ion is excreted in a intercalated cell by means of hydrogen potassium exchanger, which is present on the apical end. So actually this is called as type A cell. This intercalated cell is called as type A cell. Why it is called, we'll understand here. It's upregulated mainly during acidosis, hence it's called type A cell. In A for acidosis. So mainly during acidosis, you can see this, because you can see a lot of hydrogen is coming out and bicarbonate is going in. Means how much of hydrogen ion is excreting out, that much of bicarbonate is coming inside the cell. Means it's leading to alkalosis. But whenever there is acidosis, the cell gets regulated, and it tries to excrete more hydrogen ion in the urine, so that again the body will come back to normal. So the main function is to excrete the hydrogen out. That is the main function of intercalated cell. Next, let us see the regulation of aldosterone. So aldosterone regulation, whenever there is hyperkalemia, it's the most potent stimulus. So whenever there is high potassium in your blood, then aldosterone gets activated and it tries to excrete out the potassium in the urine. And hyponatremia, that is whenever you have low sodium levels in your blood vessels, because here you can see the sodium is getting reabsorbed. And hypertension, of course, when you have higher hypertension. And activation of RAS system, that is renin angiotensin aldosterone system, then also it can regulate the release the aldosterone. So the half-life of aldosterone is just 20 minutes. So now we'll move on to glucocorticoids. So our glucocorticoids, mainly we discuss cortisol. So these are mainly released from zona fasciculata, right? So 90 to 95% of cortisol is in the bounded form. The bounded form is binding to a colloid binding globulin, also called as transcortin. So remember, cortisol is always in bounded form. That too, that bounding protein name is colloid binding globulin, also called as transcortin. And the half-life of cortisol is 60 to 90 minutes. This is important. So here you can see, as it is having most of the binding with the protein, it's always staying in the circulation, so it's having higher half-life when compared with aldosterone. Aldosterone half-life is just 20 minutes, but half-life of cortisol is 60 to 90 minutes. Now let us check out what are the cortisol functions in metabolism. So metabolism, of course, we have protein metabolism, carbohydrate metabolism, and lipid metabolism. So what cortisol is going to change in them, let us see. So mainly in protein metabolism, it causes dual effect, that is either it can do catabolism or anabolism. So first we'll see what it catabolizes, mainly muscle proteolysis. So always catabolism is breakdown of something. So you can see here in the muscle, the cortisol will go and break down the protein in the muscle. So because of that, they will release alanine. So remember, catabolism, release of alanine by muscle protein breakdown. And next, another function is anabolism. It is taking place in the liver. What it does is increase the plasma proteins. So you can see here, like what mainly cortisol is doing in the protein metabolism is increasing the protein, because here in the muscle it's proteolizing and increasing alanine, and here in anabolism also in the liver it is increasing mainly plasma proteins. So proteins are increased by cortisol in a protein metabolism. Next, what is a clinical correlation is Cushing syndrome. So what is Cushing syndrome? Here actually there is increased level of cortisol. So the person will have muscle weakness. Of course, why? Because cortisol will lead to proteolysis of muscle protein. So Cushing syndrome is associated with muscle weakness. And next, let us see carbohydrate metabolism. What does the cortisol do here? Mainly it produces glucose from non-carbohydrate sources, that is gluconeogenesis. So we know gluconeogenesis is mainly we produce glucose from amino acids, like non-carbohydrate sources. So here the non-carbohydrate source is alanine. So that's what in the catabolism, before you have seen here in protein metabolism, that because of muscle proteolysis there is lot of alanine, and this alanine is now used here as a non-carbohydrate source for gluconeogenesis. And this causes, of course, hyperglycemia, because new glucose is forming, right? So it will increase more glucose in our blood. And pathological high levels of cortisol may lead to adrenal diabetes mellitus. Of course, diabetes mellitus itself, what? Whenever there is hyperglycemia in the blood, right? So there are chances of pathological high levels of cortisol may lead to adrenal diabetes mellitus. We are queuing the word adrenal here because we need to mention that because of adrenal gland, especially because of zona fasciculata, which is releasing a glucocorticoid cortisol, which is leading to adrenal diabetes mellitus. Next, let us see the lipid metabolism. Cortisol enhances lipolysis and increase free fatty acids. So even the free fatty acids level also increase in the blood. Now let us see what are some different functions, other functions of cortisol. Mainly it has anti-inflammatory function, that is it reduces the level of prostaglandin, histamine, and also phospholipase A2, interleukin 2. So you can see these are all the components which are useful to form the inflammation. But here you can see cortisol is anti-inflammatory. It stops all the prostaglandins, histamine, phospholipase A2, interleukins 2. So it requires large doses of cortisol, but to form this anti-inflammatory function we need always large dose of cortisol, then only it can have this anti-inflammatory function. So cortisol mainly affect on the bone. It also affects on the bone. It stimulates the osteoclast. So always osteoclast is a bone breaking hormone, that is it resorption, it leads to bone resorption. So high levels can even lead to osteoporosis, that is whenever the bone is more breakdown, it will lead to more release of calcium in the blood. So you can also say hypercalcemia is seen in a blood, whereas you can see in the bones there is bone resorption and also osteoporosis if there is very much high level of cortisol in a body. And next we'll go to cortisol effect on blood cell. So in blood cell it will decrease eosinophils and lymphocytes. Eosinophils which are mainly are allergic sensitive cells, and lymphocytes are white blood cells, and it increases mainly RBCs and neutrophils. And cortisol effects on GIT. In GIT it increases gastric acid secretion, and high levels of cortisol cause peptic ulcer. Of course, if more gastric acid, peptic ulcer. And next, cortisol effects on reproductive system. So it's a negative regulation towards the reproductive system. It decreases the gonadotropin releasing hormone. If it decreases, then all the hormones, female hormones, male hormones are also reduced. And next we have permissive action. That is, the presence of cortisol enhances the action of other hormones. Like for example, catecholamines. In the presence of cortisol, it will lead to lipolysis, bronchodilation. So all these functions of catecholamines are seen only in the presence of cortisol. So this is called as permissive action. Means in the presence of cortisol, they are having higher function. Next, let us see adrenal sex steroids. So of course now we are moving to zona reticularis, because which is that is one which produces this sex steroids. So they are mainly DHEA and androstenedione, which are found in both male and female. Actually these are the male hormones, male sex steroids, but they are also found in female. So why they are also found in female? Because their function is to sexual drive, that is the libido. For the libido, even in female they have this zona reticularis sex steroids, and they're also useful for growth of axillary and pubic hairs both in male and female. So this is all about our adrenal gland complete revision. Next we'll move on to our calcium homeostasis, which is the last part of our endocrine physiology revision series. This is the last part of our revision series of endocrine physiology, that is the calcium homeostasis. So calcium mainly forms normal, calcium forms are like they are divided, total calcium is divided into two types. 50% of calcium is like free form, active form, whereas 50% of calcium is bound form, especially with proteins like albumin. And the normal calcium level present in our body should range between 8.7 to 10.2 milligram per dl. So 8.7 to 10.2 milligram per dl is the normal calcium level range in our body, and that total calcium in our body is divided 50% into 50% is active form, free form, and also ionic form, and 50% is bound form, especially with protein albumin, and bound to albumin and its inactive form. So you can see the free and bound form levels are determined mainly by either blood pH or albumin. But blood pH is the most important one, so we are going to discuss it now. So blood pH, it's mainly depend on either acidosis or alkalosis. In acidosis condition, there is low pH. So whenever there is low pH, there is nothing but increase in hydrogen ions binding to albumin in the case of acidosis. So actually our calcium should bind with albumin, but here already this hydrogen ion is bound to albumin, so free calcium is more here because it's not bound to albumin. So it will lead to hypercalcemia in a blood vessel. Next, coming to alkalosis condition. So here the blood pH is very much high, that is nothing but decrease in hydrogen ion concentration. So now as there are low hydrogen ions, there is more albumin to bind with calcium, so there is more calcium binding to albumin, and increase the bound calcium decreases in free calcium. So bound calcium is more when compared with the free calcium. So this results in, of course, hypocalcemia in our blood vessels, and hypocalcemia will lead to tetany of different kinds of muscles, smooth muscles. So now we are going to see the calcium regulation which is mainly done by 3 different hormones. The first one is parathormone, which is nothing but released from parathyroid, and also vitamin D and also calcitonin. So these are the 3 which regulate the calcium. In this, the parathormone and vitamin D mainly enhance the calcium levels, whereas calcitonin drop the calcium levels in our body. So now let us see the 3-organ model. The 3-organ model is the bone, GIT and kidney, because these are the 3 which are mainly responsible to calcium. Bone is a bank of calcium. So whenever there is excess calcium in our blood, then what our body does is takes more calcium back into our bank, that is bone. And whenever there is low calcium in the blood, from the bank we will take out some more extra calcium and send it to the blood vessel to maintain the normal level of calcium. And GIT, from the GIT, the food we eat, from that the calcium comes into the GIT. And kidney is useful to, how much we need to excrete out the calcium to maintain, like if our body calcium is low, we will excrete less calcium. If the body calcium is very high, we will excrete more calcium in urine. So this is about kidney. So now let us see the parathormone, which is a main hormone which is useful in calcium regulation. So its action on bone is mainly the source. We'll see the action of parathormone on bone now. The source of this parathormone is mainly coming from the chief cells of parathyroid gland. And actually in the parathyroid gland we have chief cells and oxyphilic cells. From mainly chief cells we'll get this parathormone. And parathormone mainly contains 84 amino acids, so it is nothing but a protein hormone. And the drug form of parathormone, that is nothing but the agonist of parathormone, is teriparatide. And the actions of parathormone on bone, there are mainly 2 cells in the bone, that is osteoclast and osteoblast. Parathormone receptor is present on mainly osteoblast. Osteoblasts are the bone forming cell, whereas osteoclasts are bone destroying cells. So mainly parathormone receptor is present on osteoblast, and it produces the rank ligand, and this rank ligand induces the differentiation of osteoclast. So you can say it's like indirectly osteoblast is indirectly having an effect on osteoclast by means of this mediator, that is rank ligand. And by action on osteoclast, this is increasing osteoclastic activity. So because of this, there is increase in bone resorption, that is lot of bone is destroyed, so that lot of calcium and phosphate are coming now into the blood circulation. So whenever there is parathyroid hormone, you can see hypercalcemia in blood vessel because lot of calcium and phosphate are coming into the circulation. Now let us see the clinical correlation which is associated with it, especially in the treatment of osteoporosis. The rank ligand blocker like denosumab is used, which is a monoclonal antibody for the treatment of osteoporosis, because in osteoporosis what happens, there is loss of osteoclast activity. So to prevent that, we need to block the rank ligand so that the osteoblast activity will not show on osteoclast, so that there will be decrease in osteoclast activity, so that the bone can be furthermore not destroyed. So the drug which we use is denosumab is used, and which is a monoclonal antibody. It's a monoclonal antibody, not a drug. And next, coming to the osteoclast. Osteoclasts mainly cause bone resorption with the help of acid proteases. So the main proteases, the main protein which is useful for bone resorption is acid proteases present in a osteoclast. The calcium is stored in the form of hydroxyapatite crystals, that is formula calcium phosphate crystals normally. And parathyroid hormone effects are acid proteases act and destroy the hydroxyapatite crystal. This results in increased calcium and phosphate levels. So you can see whenever the parathyroid acts, but mainly by its acid proteases, it mainly destroys this hydroxyapatite crystal, so that calcium and phosphate levels are increased in our blood. Next, coming to parathormone action on kidney. So till now we have seen how parathormone is acting on bone, and now we are going to see how parathormone is acting on kidney. So kidney is mainly responsible for overall action of parathormone. Parathormone increases the calcium reabsorption from the distal convoluted tubule, and at the same time it also increases the phosphate excretion in the proximal convoluted tubule. So you can see calcium is getting reabsorbed and coming back again into the blood, whereas phosphate is getting excreted out. So by inhibiting sodium phosphate cotransporter mainly in the PCT. So how this phosphate is getting excreted? By inhibiting this co-transporter. If the co-transporter is inhibited, of course the phosphate will be remaining in the urine and it will come out. So parathyroid is also known as phosphate terminating hormone. Parathyroid we can write it as PTH, right? PTH, P for phosphate, T for terminating hormone, or also called as phosphatonin. Why we are calling phosphatonin? Because calcitonin is the one which decreases the calcium. Means at the same time as this parathyroid hormone is decreasing the phosphate, so it is also called as phosphatonin. Next, GIT. The parathyroid has indirect action on GIT. It increases vitamin D from the GIT and increases calcium absorption. So you can see it's an indirect effect. Directly it's not acting. It's indirectly increasing the vitamin D, and that vitamin D is absorbing calcium. So parathyroid overall action is mainly increasing the calcium and decreasing the phosphate. So vitamin D is how now vitamin D is useful for calcium regulation. Let us see. So mainly on the skin we have 7-dehydrocholesterol, and this is present on our skin. By means of sunlight we get UVB rays, which has 280 to 320 nanometers. So this UVB rays acting on the 7-dehydroxycholesterol, it converts it into vitamin D3 in the skin. It's an still inactive one. So you can see for vitamin D status 25 hydroxy vitamin D3 is used, and vitamin D3 in the skin is inactive, and after getting into the liver by means of 25 hydroxylase, this inactive vitamin D3 is converted into 25 OH vitamin D3, which is vitamin D lab estimation. This is in our community medicine, we can integrate it. So for lab estimation of vitamin D3, vitamin D, we mainly use this 25 OH vitamin D3. And in the presence of 1-alpha hydroxylase, especially in the kidney, especially proximal convoluted tubule, this 25 hydroxy vitamin D3 is converted into 125 dihydroxy vitamin D3 or calcitrol, which is a real active form. So this 1-alpha hydroxylase enzyme is a rate limiting enzyme because it is the main one which is converting the inactive form into the active form. And let us see what are the actions of vitamin D. So mainly on GIT, calcium by means of vitamin D only the calcium is absorbed, especially more in duodenum. You can remember like vitamin D, D for D, duodenum. And vitamin D mainly forms calbindin. Calbindin is a calcium binding protein. So increased calcium absorption from the duodenum is mainly by means of vitamin D. And next, in the bone, vitamin D receptors are present on osteoblasts, which mainly produce rank ligand, induce differentiation of osteoclasts, increase in bone resorption, that is increase calcium and phosphate in a blood vessel. So this is same like parathyroid hormone. And vitamin D in the kidney increase the calcium reabsorption, especially from DCD, and also increase the phosphate resorption. So overall action of vitamin D is increase phosphate and increase calcium levels. So you have seen before, parathyroid decreases the phosphate, whereas vitamin D is increasing both the phosphate and also calcium levels, because kidney vitamin D also used in increase in phosphate reabsorption. Not only calcium, also phosphate kidney. Calcitonin source is parafollicular cells of thyroid gland. Drug form of calcitonin is sulcatonin. It's mainly coming from salmon fish. So calcitonin, its main source is parafollicular cells of thyroid gland, and the drug form of calcitonin is sulcatonin, salmon fish. And actions: bone, calcitonin receptors are present on osteoclast, inhibits osteoclast and prevents the bone resorption, whereas in kidney, increase the calcium excretion. Clinical correlation is the medullary carcinoma thyroid, there is a tumor of parafollicular cells, excess calcitonin secretion, therefore calcitonin is used as tumor marker. So medullary carcinoma thyroid, tumor of parafollicular cells, excess calcitonin secretion is used as a tumor marker, because in this tumor mainly we will see calcitonin. And hypercalcemia of malignancy, it occurs as a part of tumor called paraneoplastic syndrome and seen in lung carcinoma and squamous in lung carcinoma, especially due to squamous cells, and small cell carcinoma mainly due to the secretes PTR, that is parathyroid related peptide. So this is all about very quick revision of calcium homeostasis. So by this we have completed our series of endocrine physiology revision. Next we will go to a reproductive system, male reproductive system and female reproductive system.